Great. Thank you so much for the introduction and the invitation to speak. It's really an honor to be slated with such wonderful people. I was really excited when I was asked to present on this series of um, uh, informational sessions, and I found out that I follow Carrie Nolte, and she's mentored me, has taught me a lot, was advocating for harm reduction when I was being saved by naloxone and I was an injection drug user. And Carrie hit on so much of what I thought I was going to cover, the data and the research and the evidence and why Northern New Hampshire needs a syringe services program and other types of harm reduction services. And I've been faced with a lot of really unfortunate events in my life around overdose deaths, disease, loved ones facing incarceration. And some of my harm reduction mentors with the New England Users Union have been throwing around, make harm reduction fun again. Have fun with this. And so I kind of had fun with this one. I really try to be as genuine and honest wherever I can. I'm going to throw a lot of information at you over the next 28 or so minutes. If you have questions, definitely pop them into the chat and I can look at them periodically, but there's going to be time for questions at the end as well as breakout groups. As you can see here, I'm going to talk briefly about myself, my lived experience, and we'll talk about harm reduction, and then we'll look at recovery-oriented systems and how, as we look at addressing the epidemic of drug use and substance use disorders, we really need to be emphasizing concepts of recovery-oriented systems. And then we're going to dive deeper into harm reduction, syringe services programs, like the one that I'm operating and expanding. And then we'll have time for questions, and then we'll have breakout groups. So as I kind of touched on, I'm a former injection drug user. I both used and sold drugs for about 10 years and have been in recovery for about 5.5. It'll be 6 years in December. These pictures on the left are me about to go to jail and detox from benzos and opiates. The next picture over is me injecting cocaine in a tent. Much of my adult life, I lived in homelessness because that kind of met my needs. And the way I would describe my drug use is really that, drugs did for me what society wasn't doing for me. They offered what I wasn't getting at home and, from the world around me. And I grew up with, I know now to be an anxiety disorder. I was called bipolar. I was called a number of things, but I didn't have language for that growing up or an education about drugs. And what I understood about drugs is that people did them because they were losers and, there wasn't. And so when I was confronted with using drugs in high school, the popular kids were using them and drinking alcohol. My friends were. And so I decided to partake. And I went on about a 10-year run of chaotic use of drugs. I became an injection drug user. I'm alive because of naloxone. 3 different times, first responders came into my life and reversed my overdose with naloxone. And that's me with Jed and Craig, that third picture over. I was doing kind of some compassion fatigue training for first responders, and 2 guys who were at my last overdose in 2014 were in the audience, and we connected and shared stories and really grew empathy and connection and really brought to light the healing power of storytelling. And storytelling is a big part of my recovery journey. And the picture on the far right is me a few months ago operating what is now the Claremont Exchange. The Claremont Exchange is a program of the HIV/HCV Resource Center in Lebanon, New Hampshire. We work with folks in both Vermont and New Hampshire. And the program that I'm operating, the Claremont Exchange, was actually the first syringe services program in New Hampshire legally. And it was been a project of Dartmouth medical students since 2015. It was originally called Project 439. And starting in January, I came out here with the goal of expanding into Sullivan County and Grafton County. And it's really been an amazing experience to use my lived experience to help others in a community I'm new to, really get to know people, really emphasize, the principles of harm reduction that saved my life. Because not only am I alive because of naloxone, but I'm healthy because of harm reduction. And when I was 20 and a chaotic injection drug user, people would two people specifically came into my life and educated me and supplied me with sterile syringes illegally. And I had another friend who I called my clean rig fairy. She would come and deliver me sterile syringes when I was really chaotic using alone and be with me. And I didn't know that that was harm reduction, but because of people coming and educating me about the behavior that I was engaged in, I'm alive and healthy and I have a clean bill of health, and I'm now able to go and meet people and share my experience and then share some accurate information and provide services to people who are going through what I'm going through or what I've gone through in the past. And really, it's been an experience of compassion and faith and learning to really meet people where they're at. And so we're going to talk a little bit about harm reduction directly. As far as like a universal concept, what is harm reduction? I think at this point, the folks on the call probably have an idea as to what harm reduction is. Involves overdose prevention strategies, syringe exchange programs like the one you see there with Dave Purchase. It might include supervised consumption sites. But really, harm reduction is a universal concept that's all around you. We use it every day. It's just any practical strategy or idea aimed at reducing negative consequences associated with risky behaviors. So anything human has a level of risk associated with it. Any behavior has risk associated to it, and any human behavior serves a purpose. We don't do things for no reason, and that extends to drug use and harm reduction philosophies when it comes to intervening into drug use is really asking, what are the benefits to this behavior? Why is it that you're engaging in this behavior? And really, it took me a long time to understand why it was I was using, why I was self-medicating. And I really wish that I learned as a child and in primary prevention what I learned as an adult, utilizing substance use disorder treatment. So yeah, it's universal, personal protective equipment. I don't really want my friends to jump out of a plane, but if they do, I want them to wear a parachute. And I don't really want my friends to drink alcohol excessively and get drunk, but if they do, I want them to be at a supervised consumption site where they employ harm reduction principles. I want them to be at a bar, someplace safe. And we use this every day. I'm sure you can think of a bunch of different ways to use harm reduction. But according to Harm Reduction International, what we're talking about today is a set of evidence-based practices that minimize the negative impacts of drug use and ineffective drug policies. Harm reduction is grounded in principles that protect human rights and improve public health. It incorporates a wide array of approaches, including abstinence, designed to meet people where they are and offer opportunities for people to improve their health and well-being. And so really, as far as human behavior serving a purpose and drug use being, kind of filling a gap in someone's life, we really need to understand that there's no recorded human history without drug use. There's always been some form of intoxicant taken by human beings. It's part of who we are as a species. And really the idea that we should prohibit that and punish people for it is only 100 and some odd years old. We call that prohibition. We've really proven that prohibition doesn't work. And it actually goes against everything we know about substance use disorders, because we characterize a use disorder as continuing to use despite negative consequences. So we offer punishment and negative consequences. And as a result, we see the overdose crisis, the rising rates of HIV and viral hepatitis. And really, we all have a relationship to drugs as well. And avoidance of drugs is a relationship to drugs. And really, if we think about, the caffeine I'm drinking, maybe the nicotine some of you will use later, this is kind of part of our society. And so harm reduction acknowledges that. It doesn't condone, endorse, or encourage drug use. Harm reduction just acknowledges that this is something that happens. And it's not about simply meeting people where they're at, but it's supporting them to make better choices and taking them with us. It's not just meeting them where they're at, it's taking them with us and empowering them. And it's not about saying, whatever happens, happens. This is a free for all, go do whatever you want. This is about evidence and research and a public health framework to address a healthcare issue, whether we're talking about substance use disorders, HIV, viral hepatitis, COVID-19, mental health crises. we treat these healthcare issues as law enforcement issues and a crime. And it's really about putting professionals in response to these public health crises that we have. But right now, we really only know prohibition and law enforcement dealing with these issues. And really, we've proven time and time again that we can't arrest our way out of this problem. We need to support people to find the recovery that makes sense for them. And it's really not about helping a person who has stopped using drugs or who has never used drugs to start using. Um, no one's ever shown up to a syringe services program and said, I'd like to inject for the first time today. And this is certainly not about legalization, but it's about creating a pathway to and a pathway of recovery. Because if we use SAMHSA's definition of recovery, it's simply a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. I like this because more people can identify as being there, even if they're not abstinent, sober, or clean. And it really emphasizes the importance of human potential and full potential. And for me, I feel like that's limitless in recovery. I can always improve where I can, improve by 1% wherever and however I can. But for many people, their full potential includes self-medicating. It includes some sort of drug-taking behavior. And for those folks, we really need to have conversations about drug use on a continuum, because we're all born abstinent of drug-taking behavior. Most human beings, and especially most Americans, will experiment with caffeine, nicotine, alcohol, cannabis, whatever that may be. And as we go left to right on this continuum, fewer and fewer people ever hit that point. I don't know how many people, but I would say most people don't ever have a conversation about moderating their alcohol or drug use, but some do. But, 5 years in and out of addiction treatment, I never heard that M word once. And we know now, based on the newest data I've seen, that about 16% of housed Americans meet criteria for a substance use disorder. But we really kind of treat this like a black and white issue of either abstinent or chaotic use. But we really, harm reduction is oftentimes about talking about moderation management and asking people questions that elicit self-examination and looking at the role of behavior in someone's life and asking them, is it your goal to be abstinent? If it's not, that's okay, but what are your goals? And as soon as we start defining someone's goals, we're kind of failing them. And so harm reduction really motivates people from within. It's that kind of natural motivation, and asking people, what motivates you to change? What do you want your life to look like? Asking again, what are the benefits of your drug use? And I hear a lot of people telling people who use drugs, stay safe. That's not really helpful, but it's about asking, how are you staying safe? And asking these open-ended questions to really help people examine their behavior and protect themselves. And, for the most part, treatment for use disorders have gotten a lot better, but we really still have an acute care model for substance use disorders. So the idea is that people hit a bottom, they meet diagnostic criteria, insurance pays for it, they access this treatment, and we believe that this is really curative and they're going to come out and love their life and it's going to be great and wonderful. And then we look at outcomes and we say that 10% of people are successful because we define success as abstinence. But if we look at recovery-oriented systems where the needs of individuals are met without contingencies, and you have a society or a system, and this could be a system of healthcare, this could be a system of really anything small to really big, this could be an agency system, but it's really about allowing people who are seeking recovery to fill in the world around them and decide what it is that they have for that recovery capital or that social privilege, and really figure out where the gaps are. And in my experience and the experience of many people who in recovery, once you start to fill in the world around you with these things or whatever things are most important to you, drug use doesn't fit in anymore. But what we do is we send people away or put people in treatment and tell them, don't ever use drugs again. And it leaves multiple empty gaps because those behaviors were serving a purpose. The drug taking was doing something for them. And it's really about allowing a person to have a whole health approach, that HIV approach, to define what it is they want to work on and fill in the world around them. So recovery-oriented systems, the work of William White, really great stuff. Could talk about that all day, but As it relates to harm reduction, you really can't have this without harm reduction, because harm reduction keeps people alive until they enter recovery. And with harm reduction, all drug-related death and disease is preventable. Overdose death is 100% preventable, but the CDC predicts that 75,000 Americans will die in 2020 of a drug overdose. This is preventable. It's keeping people alive to find recovery and reach their full potential. Um, and so for folks that we're working with, whether they're motivated for abstinence or recovery or not, it's about meeting them where they're at and understanding them, seeking to understand them, having faith in them. So much of harm reduction is about faith in people and fostering connection. And harm reduction strives for any positive change, any step in the right direction. It's person driven, it's not coercive, there's no contingencies or ultimatums or this for that. It's supportive and it's not punitive. And this framework for working with people with a use disorder aligns with what we know about the condition. But ultimately, we tell people to sort out your condition, minimize your symptoms, and then come to us when you're ready to work with us. And if you exhibit symptoms, we're going to pull services away, whether that's, housing, treatment, medicine, etc. And it really is contrary to everything we know about use disorders. Um, it's also a framework for understanding drugs and drug use viewed through the lens of science and not morality or ideology or fixed ideas. Harm reduction really emphasizes the most up-to-date research and evidence, and looks at the context of drug use as well, using the work of Dr. Norman Zinberg. Much of our society focuses primarily on the drug that we're talking about. What's the mechanism of action? Is it an opioid, a benzo, a stimulant? How are people using it? Is it legal or illegal? But we fail to oftentimes look at the individual or the set or what somebody brings to the table. And so that's somebody's physiology, their mental or emotional state, also their cultural identity and sense of belonging. And that's a big part of using drugs and other behaviors like gang activity or sex work, because ultimately we're social creatures looking for a sense of belonging. And me personally, when I found selling drugs, that really put the wind in my sails, because I had a sense of belonging and well-being, because I wasn't getting attention at home. And when I found people that gave me attention for whatever reason, it really led me down a path of suffering. And in my day-to-day work, I see so much suffering, needless suffering, and like just unbearable bottoms, because people aren't empowered and they're really marginalized. And so as far as the individual, it comes back to the expectation and motivation for using the drug. I could have two people using the same opioids, and one could use it to make the voices in their head stop, and the other one might be using it to treat physical pain. That's two different pathways of recovery and two different really approaches, but we really offer these cookie cutter approaches to addiction recovery that really makes sense for people with social privilege like me. Like, treatment saved my life, and I'm very grateful for it, but I'm also a straight cisgender white male from New Hampshire who had enough social privilege that when I got out of treatment for the fourth time, my parents could house me for several years, and I was able to seek employment because I wasn't a felon, because I got alternative sentencing about it 6 times. So really it's about, looking at the individual and the community around them, someone's socioeconomic status, their environment, support or lack thereof, with who someone uses, and the cultural attitudes towards the drug and its users. There's a lot of stigma against stimulant users right now, and I work with that myself. And so really it's about looking at the whole picture of drug use and figuring out, where can we reduce harm? Where does the harm lie? And if you use the drug alcohol, oftentimes we talk about the setting. Are they driving? Are they walking in the streets? Are they around children? Do they have a safe ride home? Are they at a supervised consumption site? So really, sometimes these conversations help people to protect themselves who aren't ready to stop using. And the goal of harm reduction is ultimately to improve the health and well-being of individuals and the community around them, but also to highlight and address the roles of discrimination due to poverty, racism, classism, sexism, isolation, trauma, and other inequalities and drug-related harm. Throw homophobia in there, really throw anything in there that is going to marginalize somebody. And oftentimes traditional treatment and recovery systems tell you not to talk about this stuff because the problem is you. This is a disease with no known cure, and therefore come to this program. that really enforces the drug war quite a bit, and it really takes away a lot of conversation about personal responsibility and collective responsibility. But the truth is that many people are using drugs to deal with these conditions in our society, and I really see substance use disorders really as a manifestation of how somebody is impacted by the war on drugs. How insulated are they by social privilege that they can withstand the inequities in our world, because we have classes of people who can use cocaine, benzos, and opiates with little to no pathology, and we worship them. They run Wall Street, they're Hollywood, they're celebrities. But we see people who are marginalized who develop these use disorders. We then vilify them, punish them for their behavior. And that's a lot to unpack. That's a lot of stuff there. But really, harm reduction is about showing people dignity and respect and empowering them so that they end up reducing harm. And that's really not what you see in a lot of services that are available to drug users. Um, and so the goal again is to, and for harm reduction as it comes to supporting somebody, it's about offering somebody to talk to, open and honest conversations, educating people about consent and understanding if they're safe, and empowering them to make decisions that are based on education and understanding and their best interests. And so harm reduction is really about education and preventing death. And there's a lot of work and money going into access to cost-free naloxone. And it's important to remember that the person who's most likely to save a life with naloxone is somebody who uses drugs. And supervised use is a concept that seems a little radical, but when I talk about supervised use, I'm talking about creating a culture of people who don't use drugs alone. Because anytime somebody I love died of a fatal overdose, they were alone behind a closed door because of stigma. And stigma is just another way to talk about oppression or discrimination. Stigma is a nice way to talk about oppression, but really we're talking about very marginalized people who are at risk for disease. And that's really why we're here. And it's really wonderful that the government sees that the cost benefit of treating people with HIV and viral hepatitis. And really, it's important to have people know their status. And the people who are most at risk for HIV are men who have sex with men, people who use drugs, people who engage in sex work. And so harm reduction meets very marginalized people and provides healthcare services. And we're seeing increasing rates of hepatitis, HIV, and other infections from injection drug use. And this is really, we're talking largely about injection drug use, but you can transmit these diseases obviously through sex and snorting drugs. And so really the important thing to emphasize is that this year, the CDC updated guidance for hepatitis C and said that every American adult should be tested at least once in their life, and women should be tested every time they're pregnant, because it's estimated that 1% of all adults in the US are living with a hepatitis C infection, and most don't know it. And that's a whole other presentation to get into. And also we're seeing a lot of infections from injection drug use, and people are dying slow, painful deaths. And this is 100% preventable. And that's why programs like the Claremont Exchange and other programs of the HIV/HCV Resource Center exist, because this is all preventable. And now there's funding available to bring services like a syringe services program to the northern region of New Hampshire. Like I said, the goal of my job over this 3-year project is to expand to Sullivan County and Grafton County. And that strategy does include a program in Littleton and the Plymouth region as well. We see folks in Lebanon, where our primary office is, and through mobile outreach, we see a lot of people in the Claremont area. And really, these programs are backed by 30 plus years of research and evidence. There's never been research that said these programs are a bad idea. And in fact, most recent research has shown that people who inject drugs are 5 times more likely to access substance use treatment and 3 times more likely to stop injecting if engaged with an SSP. And that's my experience in Claremont. I meet very marginalized people who are living in the shadows of everything I just kind of talked about. And I'm offering coherent conversations and lived experience and really just an open ear for some people. And really, the engagement tool is the syringe or the naloxone or the first aid kits or the PPE or whatever it is that we're offering, the HIV and Hep C testing. But really what happens is it's a point for crisis intervention, wound care, and we're starting to develop telemedicine support with Dartmouth Hitchcock to have our folks be seen in their home or wherever it is they are through telemedicine. And I've been able to have 2 people prescribed antibiotics for their wound from injection just through telemedicine. So really hoping to evolve services for drug users beyond treatment, because we really want to medicalize this and offer everybody who uses drugs treatment. But we know that not everybody's ready, but they should have access to healthcare and disease testing, overdose prevention strategies, access to healthcare and health insurance, and care coordination. And really, I've seen so many people this year access Suboxone through telemedicine or other means that most of the people I've seen with the Claremont Exchange are no longer using the program. And that's all peer-to-peer distribution. In January, taking over the program, it was housed for 3 hours a week. It was accessible in Valley Regional Hospital. Starting in March when COVID hit, we went to all peer mobile outreach. So people call the 276 number that goes to a phone that I carry, and I go to meet up with them. But most people who get supplies from the Claremont Exchange are doing that through peer-to-peer secondary distribution. And I'll kind of get into that in a second, but this could look very different place to place. We give out sterile supplies because anything you see here could be a vector for disease. And because folks never had a real drug education, a lot of what I'm doing with people now is telling them to, heat up their solution with liquid because it's going to kill bacteria, use a new cotton every time. And so we not only give out sterile syringes, but we also give out sterile supplies. And we also educate people on sharps disposal and different options for how to dispose of syringes safely. And I have a couple of people, and they love their red bin. They walk up to the car with it out of the bag, just this bright red bin full of syringes, and they take so much pride. And it's really this idea of empowerment. They become empowered and they become healthy, and then they start volunteering. And then they get to like that 1-for-1 exchange where they're giving me more syringes than they get from me because they're injecting less and they're collecting from their friends, and then they're gone. And time again, I've worried that they die or what have you, but it's really been a privilege to hear from other participants that people are doing really well, and that, in these really troubling times, most of the people I was originally seeing are no longer injecting, and they're in some form of recovery. So it's really been this wonderful experience, and we're trying to track some of that linkage to care better. But again, we're working with Dartmouth on access to treating hepatitis C, mostly through telemedicine. And a lot of our folks are surprised to learn that they can access hepatitis C treatment and not stop using drugs. They don't need to maintain abstinence, because Medicaid would rather pay for 5 rounds of Hep C treatment that's now really cheap, the medications, than paying for a lifetime of cancer, liver cancer, and other chronic hepatitis C issues. And the CDC will tell you, and the Surgeon General, Jerome Adams, will back this up. These programs save money, they reduce disease, they save lives, they reduce needle stick injuries for first response, and they increase access to treatment. And there's also endorsements by all these wonderful agencies, from the last couple of Surgeon Generals to the World Health Organization. There's not really much you could say that says that these are syringe service programs or SSPs are a bad idea. And this is, I'm going to wrap up here in a second. I'm just about hitting the 30-minute point, but this is data for the Claremont Exchange. This is who I've seen from January 1 to September 30th. And that's 78 unique clients. I would say most of my meetups, I usually have a crew of like 3 or 4 people that are doing secondary distribution. So rather than seeing 10 people who each get 100 syringes, I see one person and they get 1,000, and they go out to the community. And really, that's how we've gotten supplies to 548 people. And the stories that have come out of that are incredible, because people that won't access an SSP are living in the shadows and living in really bad conditions. But in 9 months, I've had my volunteers and other people tell me that the Narcan we've gotten out has been used 71 times the large majority of those, they did not call 911. And the program went from a 25% return rate up into the 60s and 70s really quickly because of my volunteers. And there's been a handful of provider referrals, but not nearly as many as I would like to think. It's all been drug user to drug user, peer expansion. And so when we talk about potentially bringing a program like this to Littleton or Plymouth, there really doesn't need to be a building or any sort of big um, thing that happens. It's really the best programs, and the evidence will back this up, are peer-to-peer secondary distribution. And so thank y'all for listening. Hopefully I covered everything. Happy to answer questions, and I really look forward to these breakout groups.
Ryan, wow, that was amazing. I learned so much. Thank you for sharing that and for sharing your story too. It makes it even more powerful. I'd love to take questions and comments. There'll be time for more conversation, but questions right now, things that stood out to you, clarifying questions that you're wondering about or wanting to know more from Ryan right now. You can feel free to just unmute yourself and share. You can also add it in the chat if you feel. Wondering about Coos County. Yeah, what are the plans to expand right now, or what are you doing? I guess, yeah, Coos County, I'll ask.
So I've heard a lot about lack of syringe access in Coos County, really the upper third, and with the closure of the Hope for New Hampshire Recovery Center in Berlin, there's really not a lot going on up there. And my wonderful director Laura is on the call, and we've talked about the need, and we've kind of said that if there are folks up there that need supplies, they can simply call the Claremont Exchange, 603-276-9698. I take calls in Grafton County. We have a Laura on the call, goes out and meets people. We also have Ryan Richards with the agency who goes out and meets people for exchange. Definitely Sullivan County and Grafton County. And if there's folks from Coos County, I would love to connect and see what we can do. Already looking at the prospect of a program in Plymouth, we're seeing the mail might make a lot of sense to get this going at first, because the upper third of New Hampshire is really expansive and mountainous. And so I would love to connect on Coos County for sure, because I know the needs there.
Great. Definitely a few more questions here. Jean is asking that they've heard many community voices express a fear that needle exchange will increase the number of needles lying around the community. Can you talk about how you are trying to increase the number of needles brought back?
I've seen that happen pretty isolated, but it's really about the principle of engaging with somebody and empowering them and educating them. And I tell them, this is your program, and if they see a needle on the ground, it's mine and it's yours. So will you do me a solid and pick it up? And I just talk to people frankly, like I would my friends as a peer. And really, people have asked me if they can go out and pick up syringes in the park for me. I'm like, absolutely. Like, can I get you some gloves? Can I get you a grabber picker upper thing? And people, like, once they understand the laws through New Hampshire surrounding syringe service programs, and they start to develop this agency and this kind of it's really cool to see what happens. But in Claremont, I've not had that problem at all. In fact, when I asked people in Claremont where the syringes on the ground were, and I went out with a few people, I did not find a single one. I went out several times to these parks. But I do get a lot back. And, if this is done right and it's really culturally responsive and there's humility to it, I really wouldn't be concerned about needles laying around. And if there are spots that want syringes picked up, let me know. I'd love to go out and maybe grab a volunteer or two and can learn about what's going on up there. But What I saw in Manchester when they stopped selling syringes at Rite Aid was that there was no syringes on the ground anywhere because they had street value of $3 to $5 for a used syringe. And so we had to roll out the Clean City Exchange in a city where there is HIV just to supply access, provide access, because things can get pretty bad for injection drug users. So it's a good question for sure.
Great. There's a few more, so I'll put a few to you. Janice is wondering about how many safe, clean rooms there are in the state, and also another question about what are the costs of standing up a needle or an exchange program. So 2 questions: safe or clean rooms in the state, and then the cost of starting a program.
So, Janice, thank you for the question. I definitely want to connect soon because y'all do this work out on the other side of the state, and there's lots of funding coming to the state to support and expand programs. For a while, until really recently, I was the only person paid to do this work full time, but there's several paid positions coming up throughout the state, definitely along the southern tier. And there's also been additional federal money that's come in alongside the 400,000 state dollars that went towards this. So for the first time ever, there's a weird amount of funding for syringe services programs. And as far as expanding north, the funding's there. We have the supplies. We just put in for extra federal money to get 3 months of supplies. And so in order to roll out a program, it would just be, some training and coming up with supplies myself to train folks. And I would rather go the peer-to-peer route and meet people who are going to use the program, and see what's going to make sense for the community. But as far as the cost to start this, it's already there. And I don't know if Laura wants to correct me or say anything to that, but it's definitely possible.
No, I think you said it pretty much correctly, Ryan. I think we fortunately the federal ban on buying syringes was lifted, so it makes it easier to access funding for specifically syringe purchases. And I think in general, like the first year of our program, we probably spent like $5,000 on supplies, and then it increased from there. But just as a startup, it depends on how many supplies you go through. I know Queen City probably spent more, but that was just us.
Okay. Thank you. Let's take one more question, or maybe 2 here, and then we'll get into our groups. Is there any movement on or pilots in communities that provide public restroom sharps? So I'm imagining the red box type of thing. Someone is asking about, is there a coalition or a group that maybe we could start a pilot? Is there anywhere else in this state where there is the public restroom sharps pilot? And then the second question is, given the outbreaks of HIV that have occurred in PWIDs around the country, Mass being most recent and close to New Hampshire, can you talk about what education around HIV testing, sexual health services, PEP and PrEP have? Sorry, that was a complicated question for me to ask. So 2 questions. Do you remember them? Sorry.
Yeah, for sure. So Janice, your question, I noticed recently when I was looking at ordering supplies from the North American Syringe Exchange Network that you can purchase those wall mount sharps containers from Nason for varying costs depending on the setup. So now that you all out at Mount Washington Valley Sports Recovery are accessing some of this new funding, it would be something to look at. Maybe your program out there could look at where you would need that. And because of passing Senate Bill 234 in 2017, that's now legal and there's no liability on the business owner. Whereas prior to 2017, there was a legal liability to put a sharps container in a bathroom. But I see them more and more in New Hampshire. And then the question regarding education for people who inject drugs around HIV. So I was working in Manchester when the Lawrence and Lowell outbreak really kind of became public, and we saw folks from that area coming up to Manchester, and it's really unfortunate how at risk everything is right now around and some of the outbreaks that occurred throughout the country were really also aggravated by lack of access to testing. Like when folks need to be tested and their viral load is high, they were not able to do that, restricting access to syringes, clearing out homeless encampments, and short-acting synthetic opioids because people are injecting more. And so really the only thing we've not been able to do since COVID was roll out our HIV and Hep C testing. Prior to COVID, Gene Addy had trained myself, Laura, and Angel, another one of our coworkers, to give folks these on-site 1-minute HIV tests. We would love to roll that out again, but with COVID-19, there's just a lot of red tape, but we just ordered surgical masks, and we have the face shield visors, and we have an office in Claremont. So we would really love to roll out HIV and Hep C testing again, because prior to COVID, we were offering all of our participants HIV and Hep C testing, and that's there. We just need to figure out how to roll that out and be physically distanced for COVID. We give out a lot of condoms. With the mobile outreach, it's really hard to have full conversations about this stuff, but we've started to do more and more written materials and different handouts. We give out a lot more condoms, and I've been able to learn a little bit about some of our participants who are engaged in sex work and have a little bit of conversation there. Yeah, like I said, more condoms, and really on PrEP, pre-exposure prophylaxis, HIV preventative, is real hard to get drug users on PrEP. It's really, really hard. And y'all do, I know in Massachusetts, they offer it a lot more, and it's very hard to get drug users on PrEP, but we try to talk about it. And ultimately, H2RC is an HIV HCV resource center. We offer case management to people living with HIV. And so we definitely offer a lot of education and different types of case management support, but really hope that answers your question.
Can I just, sorry, thanks for answering that, but I'm just going to say that, one of at AIDS 2020 this year, they presented the Boston Home Healthcare for the Homeless Project, presented data on homeless people who use drugs and PrEP, and they actually gave a strategy for how to get people on PrEP, and I'd be happy to share it with you at a different time. But they were able to keep people maintained on PrEP at about the same levels that people who like gay men who we've been studying for 15 years for PrEP. So I think that it is changing for people who use drugs. So I'd be happy to share that with you, because I think that's one of the tricky things is that, they're starting to change the way that they provide PrEP, and that will help people who use drugs better, I think. Sorry.
No, that's wonderful info. Obviously, I would love to be doing more with PrEP and testing. So hopefully this can be a point of collaboration. We can move forward and share
I would
ideas.
love to, because it's hard to know that you don't have an HIV outbreak in New Hampshire right now, right? Because from my understanding, the drugs come from Lawrence and Lowell, up to New Hampshire. And so how do you know, if you're not doing testing, that you don't actively have an active outbreak of HIV in New Hampshire, which you certainly are poised to be at risk for. So it's very interesting. So we can follow up. I can maybe give you some suggestions. Okay.
Thank you.
That's great. Thanks, AC. Are there other questions right now that we want to share? I think Ryan's going to join us for this next part too, so we can continue talking specifics and sharing some ideas and resources.
Diana put a question in the chat about the needle snip tools. Those are good for people with diabetes who use maybe 1 or 2 syringes a day and who are housed, but those needle snip tools are not recommended for syringe services programs because of the volume and oftentimes the conditions that people are living in. They oftentimes will open up and then you have a bunch of little tiny needles. And I've actually been in the recent years telling people to not break the tip off of them because there's this idea that if they break the tip off and put it in the bin, that's better, but it's like way more risk for everybody involved. So I've been asked multiple times about the syringe snip tools. So yeah, not the best for these types of programs.
All right, I'm gonna have that was really great, Ryan. Thank you so much. I think we're gonna move into some group discussion, which we've already started in a way. And I think I'll have a transparent facilitator moment with Carrie and maybe all of you. We can move into 2 smaller group breakouts, which would be, I know there's a few organizers who are on the call as well, or we can stay in full group. So I'd maybe ask Carrie what she thinks and maybe ask all of you. Would you prefer to be in a smaller group where you'd have maybe 5-ish people, 5 or 6-ish people in your group? Or would you prefer to stay in this larger group?
And continue to share resources, kind of like how AC brought up information, and that was a great start to a conversation. So we could continue having a conversation like that here. And sometimes it's more comfortable to move into smaller groups. I have them set up, so we're ready to go either way.
I'm seeing a few comments. Yeah, speak up. Go ahead.
I was just going to say, having the whole group is, I mean, there's not that many people. So
Exactly. You all good with that? A few nods, thumbs up. Okay, let's do that. Okay. Yeah, thank you, Carrie McFadden. I see the thumbs up there. Good use of the tool. All right, good. Yeah, I feel there's a few comments in chat. All right, that's great.
Perfect. That's awesome. Before we go, well, actually, let's just, if you need to take a break, if you need to stand up, if you need to kind of move around, change positions, go ahead and do that. This is kind of this is that 4 o'clock time of the day where it's nice to be able to take a little break. So let's just take a couple minutes. You need to, take a bio break, stretch, stand up, and then we'll come back and just have a large group discussion about what we're learning and what you all are seeing in the community and even more questions.
All right, we'll come back at 4:10, 1 minute after 4. Well, actually my time is 4:10, 4:11, 4:12. I'll pause the recording. Or can you? No, I can't pause it. Do you want to pause?